And I don't know what her talk will be. Anyhow, she has 20 minutes to convince us about the new regimens.
Thank you very much. So thank you, Franz and Nachi, who was gone, for the invitation, even if I'm only a medical oncologist. And we promised that we'd be ready in 1 hour to be really very fast. We decided to have an overview from me about all the new treatment options. Then Lukas is going to present some cases, and Howard, whoever he is, gives us some perspectives from the US NIH side, right? So I guess since you are not a lot of us, we can make this very interactive. Microphone, please. Oh. Sorry. So this is my conflict of interest. I'm the only one who has some. I'm very ashamed of that, obviously. So I start with just mentioning that our patients, at least a lot of them with CRPC, are elderly, right? So they have comorbidities, and that also means they have co-medication. And that can be a problem with the new oral drugs, because they are interactions. Just think about that. They have all also some reduced performance status and some compromised organ functions. Obviously, we also treat some 45-year-olds, we discussed that, but that's definitely not the majority of the cases. And at least when I talk to my patients, overall survival is important. And that's the primary endpoint of all the studies. But for these patients, the majority of them, also quality of life is very important. And I think that we should keep in mind. So just show you, you have all heard about docetaxel. I don't tell you about that again. But it was the first drug that showed an overall survival benefit, 2004. And that leads to this a little bit kind of artificial situation that we now always say pre or post docetaxel. So what came in the last years is Cabazitaxel, another taxane, Sipuleucel T, a immunotherapy, we talk about that later, Abiraterone after docetaxel first, then enzalutamide again after docetaxel, then radium. That is a little bit a special situation with some of the patients after docetaxel, but some patients deemed unfit for docetaxel. Then came the publication about Abiraterone pre-docetaxel, and now at ASCO GU a month ago, enzalutamide pre-docetaxel. And this is a graph from my colleague and friend Aurelius Omlin. So you just see where are these drugs working. So the new hormonal treatments obviously target the androgen receptor. You know, chemotherapy is just targeting the tumor cell. Sipuleucel T is an immunotherapy, and radium is targeting the bone metastasis. And I start with the CYP17 inhibitors because that's a really nice and new-in-class drug. So this is about abiraterone now. You know all that androgens are secreted from testes and from the adrenals, but they are also secreted from the tumor itself. And in all sites, the synthesis of testosterone is dependent on this CYP17 enzyme. And what abiraterone does is inhibiting the enzyme, and it does inhibit the lyase. That's what you want to do, because that's lowering the testosterone, but it also inhibits here the hydroxylase, and that leads to an increase in corticosterone, and that makes you the side effects: hypokalemia, hypertension, and edema. And that's why it's approved with prednisone. So there's newer CYP17 inhibitors in development that seem to be more selective, but abiraterone is the one that is approved. And you see here the two New England papers, one after docetaxel, one before docetaxel, and that actually was the definitive evidence that this CYP17 inhibition is working, and also that CRPC is still driven by hormones. So it's not called hormone refractory anymore, but castration-resistant. I show you, because I'm an oncologist, I have to show you some Kaplan-Meier curves, I'm sorry. But you see the overall survival was clearly, significantly improved in this post-Docetaxel study. It was not against placebo alone, but against placebo-prednisone. You should keep that in mind. So the placebo arm was plus prednisone. And about quality of life, it was also better compared to bone. The side effects, we talked about that, is even if you give prednisone, edema, hypokalemia, and hypertension, you really have to look for that in your patients. And there's also some evidence of cardiac disorders and of liver test abnormalities. So you have to look for heart problems, you have to look for your liver enzymes in your patients. And obviously, since the drug was so good, it was also tested in the situation before Docetaxel. So that was the second study, again a phase 3 study, big study, international, and again randomized against prednisone. And you have to look at that. All patients had to be asymptomatic or minimally symptomatic, and they were not allowed to have visceral metastasis. And what you see here is the overall survival had a trend to be improved, but wasn't significantly improved, but the radiographic progression-free survival was improved. And the last and third interim analysis showed exactly the same thing, trend to improved overall survival, much better radiographic progression-free survival. And I only show that because you see here, this is 35.3 months of overall survival in the castration-resistant setting. All patients with metastatic disease. That's probably the best numbers we have seen in a long time. So the nature of the disease is definitely changing, what some of the speakers said yesterday. And the FDA approved the drug in the setting before Docetaxel because of that data. Side effects, again, also in the pre-chemo setting, the same. Look at the cardiac disorders. You should really look at that, and also at the liver enzymes. Enzalutamide. This is not a completely new drug. This is a new anti-androgen. And what is new about it, it is really working on 3 levels, not only blocking the receptor here like the other anti-androgens. So it's much more potent. And then again, they started with a big phase 3 trial after Docetaxel in a 2-to-1 randomization, enzalutamide versus placebo. And this time this was really only placebo, no prednisone, because you don't need to give prednisone with the enzalutamide. That's a big advantage. And you see there was significant improved overall survival. And here also the quality of life was clearly better with the enzalutamide. Side effects, despite that the patients were much longer on enzalutamide than on placebo, the side effects were not more frequent than in the placebo group. What you should look at is what it does is fatigue. That's definitely some problem in these patients, diarrhea, hot flashes, and headache, and also some musculoskeletal pains. What is good, at least in that trial, you didn't see any cardiac disorders, you didn't see any liver problems, but one of the side effects of enzalutamide is seizures. It's a very rare side effect, but you should be aware that this is a serious side effect if your patients get it. And now this is the really fresh data that has been shown in ASCO GU. Again, enzalutamide, very nice drug, very untoxic, so why not go before chemotherapy? And that was the big phase 3 trial before chemotherapy called PREVAIL. You probably have all heard about it. And again, you see a significant overall survival benefit in that situation with 32.4 months for the enzalutamide arm, and also a quality of life that is better in the enzalutamide arm versus the placebo arm. Side effects, very similar to what we've seen post-chemotherapy. This is pretty obvious. No seizures. There was only one seizure in the enzalutamide arm, but that occurred after the treatment. So it doesn't seem to be a problem in these patients who are much less advanced than the other ones, but still look at the other fatigue, back pain problems. It is not without side effects, but is really well tolerated. So just shortly, chemotherapy. There's also a new chemotherapy on the block, that's Cabazitaxel. It's also a taxane, and there was also this big phase 3 trial that was randomized against mitoxantrone. So again, this is not nothing or only placebo. This is an active therapy as well, and you saw a significant overall survival benefit. Side effects, very typical for chemotherapy: febrile neutropenia, hematotoxicity, diarrhea, nausea, but also manageable. Then just shortly, because that's not approved in Switzerland, but it's interesting, there's Sipuleucel T. You probably heard about that. This is the patient's own white blood cells that are activated with a fusion protein. And it's very nicely to give because it's only 3 injections every 2 weeks, and then you finish with the treatment, and you saw an overall survival benefit with it. It's just very complicated to get to your patient nowadays, at least. And it is expensive. We talk about that perhaps later a little bit. Side effects are very mild, influenza-like. Then just shortly, because you hear tomorrow a talk about radium-223. This is a new radioisotope. It's an alpha emitter, and again, we've seen, and that was surprising actually, not only a really improvement in pain and in time to first skeletal-related event, but also in overall survival. So another completely different option for our patients. Side effects here were also unexpectedly mild. We all waited for the myelosuppression, but it was here, but it wasn't very severe. And it does make some diarrhea because that drug is secreted by the gut. So now we have actually the problem that we have 5 new therapies with an overall survival benefit: a chemotherapy after docetaxel, Abiraterone before and after chemotherapy, Sipuleucel T, most of the patients were before chemotherapy, radium with some patients after docetaxel, some unfit for docetaxel, and enzalutamide also before and after docetaxel. So what are we doing? The thing is, we have no data about patients who are castration-resistant and M0. So if there is a clinical trial, include patients in that trial. First-line therapy, and I now wrote in black what is approved in Switzerland. Still docetaxel is an approved first-line chemotherapy. Abiraterone is approved, but only in patients who are asymptomatic or minimal symptomatic and have no visceral metastasis. Radium-223 is not approved in Switzerland yet. It's only in patients with bone metastasis and pain and unfit for chemotherapy. And they can't have visceral metastasis because it's not working in visceral metastasis, it's working in the bone. Sipuleucel T is not approved in Switzerland. It just recently has been approved in the EU, but is in the EU not receivable. I think it's only one center in Europe, that is Paris, that is open for a trial. And that's only in patients with asymptomatic disease, again without visceral metastasis. And enzalutamide is not approved yet, but would also be in asymptomatic or mildly symptomatic patients. For second-line therapy, we actually formally have only data after docetaxel. There in Switzerland, Cabazitaxel is approved, Abiraterone is approved, and enzalutamide is approved. But you have to send a letter to the insurance company before you give it. Other options that are not approved in Switzerland yet is radium-223 and Sipuleucel T again. Third-line therapies, we don't have any data about that. for patients who are really in a good performance status and you haven't used it before, you can use all these drugs or even go to Docetaxel rechallenge. I think we talk about that later. And I hope I was fast enough, and we go to the cases.
Silke, thank you very much for this very nice overview. So we have many options, but really the question is, what should we do when the patient comes in? Lukas.
Okay, thank you very much for the nice invitation to be here in this beautiful place, to this beautiful meeting. We heard about a very, very nice overview about the options we have, and I think we have the challenge 2014 to find the right therapy for the right patient. You all know how to treat patients with a prostate cancer, what to do, open radical prostatectomy or robotic. Then, with the progression, to start with the LH, RH, hormone treatment. And since 2004 till 2011, it was clear when you have a symptomatic patient, you could start with a chemotherapy. But after that, 2011, Cabazitaxel in April was introduced, and just a few months later, Abiraterone was introduced. It starts to begin a little bit complicated for us. And since 2013 in January, Abiraterone was introduced. 2013 in September, Enzalutamide was introduced. And after the nice data of the PREVAIL trial on the GUASC 2014 in San Francisco, now we have enzalutamide before chemotherapy. I think this is a little bit confusing what to do. Our aim is to hit the target, to find the right therapy for the right patient. When you look to the PubMed publications, these are just the last 2 years. For Abiraterone, you will find 400, up to 400 publications. And for enzalutamide, you will find up to 200. It's a lot of abstracts to read. But I'm a urologist, and I have to treat patient. This is a patient, he is born 1935. He has a typical German name, Müller, and his disease was found in 2000. PSA was 7.8. He got a radical prostatectomy, positive margin, and he got a adjuvant radiation therapy plus Casodex. The PSA nadir was wonderful, 0.09. Casodex was stopped, but just 1 year later, the patient had a PSA progression with 2.85. At that point, we start a LH-RH hormone treatment, an intermediate one. The patient tolerated very good, no serious adverse events. And since 2008, the patient got a progression, and we start a complete androgen blockade. And just 1 year later, after anti-androgen withdrawal, the PSA rose up to over 200. The patient, you see, was asymptomatic, and we finally started a secondary hormone treatment. The bone scan was negative. The PSA rose just 2 months later to 500, 1 week later, 600 to 636. The imaging, the PET scan show a metastasis in the acetabulum, as well a lymph node metastasis. The bone scan was positive in the lumbar spine and the thoracic spine. And when I saw the results of the MRI, I was a little bit shocked. Multiple lymph nodes everywhere. And the MRI confirmed the bone mets. So my question to you, what would you do in 2009 with this patient? Would you say nothing? Or would you go for a study enrollment? Would you say this patient is the best candidate for a study like, in that moment, for QGAR 302, Abiraterone? Or will you say, no, we have a high PSA, we have a patient with a complete metastatic disease, this patient is the best candidate for chemotherapy? Or would you say a third hormone manipulation? Who is for one? Nobody. Who would say Abiraterone will be the best? 3, 4, okay. Who is for chemotherapy in the audience? Okay. We decided to go for QGAR. When you look to the history of the patient, the treatment started in 2000, and the hormone treatment started in 2003. We got over 6 years of treatment of hormone treatment. We have a good answer to the hormones, and we can choose this option. When you make the study enrollment, the PSA was 1,000. The AP and the LDH was high. I was a little bit nervous if my decision was right. Just 1 month later, the PSA dropped down, and 1 year later, the PSA was 1.7. The bone showed no mets. The MRI still showed mets in the os ileum and the acetabulum. It's a very sensitive imaging. And the PSA nadir, just 1 year later, or 2 years later after the enrollment, was 0.99. So our decision was not so bad. But what happens? Just 3 months later, the PSA rose, but the bone scan was unchanged. This is bone scan. Really no mets. And if you now look what happens, the PSA rose and rose and rose, but the imaging is completely unchanged. The PSA rose, and in December 2013, 2 years after the first PSA rising, the PSA was 134, and the imaging showed 2 tiny mets in the rib. The patient was completely asymptomatic. So the question is what to do now. Would you say continue abiraterone, or would you say no, now please start with the chemotherapy, or would you say this patient is the best candidate for alpha-radine therapy? So who is for 1? Okay, 3. Who is for the chemotherapy? Nobody. Who is for alpha-radine? Okay, nice options. We decided to go for abiraterone. We have a very complete asymptomatic patient. We start a chemotherapy when a patient is symptomatic. Of course, you can choose alpha-radine. You have meds. But the question now, 2014, is what is the best point and the best time to start alpha-radine? I will change the patient. This patient was born in 1945, a completely different case. When he presented to our hospital, he was already showed already a metastatic disease. Mets in the os acromius ileum. When we start with the LHRH analogous, the lowest PSA value was 40. It's not really good. 1 year later, the PSA rose up to 50, and we start a complete androgen blockade with bicalutamide. 1 year later, the patient was stable, had a stable disease, and 1 year later, the PSA was 210. The ECOG performance status was 0, and the patient was asymptomatic. The PSA rose, and 2009, in August, the patient presented with pain. So what to do now? Keep on going with the hormone treatment, or would you say no? The chemotherapy is the right therapy for this patient, or would you say combine it with a radiation therapy, or would you say no? We have the good data of the Cougar 302 trial, and you say abiraterone is the right. Who is for 1? Okay, nobody. Who is now for the chemotherapy? We have a symptomatic patient. Okay. Radiation combination, of course, is the right. Abiraterone had no place in this patient. The patient had a metastatic castration-resistant prostate cancer and is symptomatic. There is no place for abiraterone at that case. When we start with the radiation and start with a docetaxel treatment with 10 cycles. And you see, 1 year later, the PSA was 0.39. A really nice drug, cheap at the moment, and we have good response. And you know the data from the TAC 327 trial with the overall survival of 2.9 months. But you can say it's not the same like in the Cougar 302. But if you look to the subgroup analysis and you look to the PSA, what do the PSA after the chemotherapy? When you have a PSA normalization on a PSA decline of 90%, you have an overall survival for 26 till 33 months. And I think this is what we have in some trials, like in the QGA 302 or the previous trial. This is a good option. The PSA, 1 year later, rose to 6. And in August 2011, the patient presented with a paraplegia. We done a hemolaminectomy plus irradiation. The PSA wasn't so high, 78. The patient had neurological symptoms improved. We wanted to start with a chemotherapy, but the patient, 1 month later, got again new paresthesias in the legs. This is the imaging, the MRI, big mets in the lumbar spine, everywhere. And what to do now? Would you say a re-challenge with a docetaxel would be the right thing, or would you say combined with a radiation therapy, or would you go for Cabazitaxel as a second-line option in that moment, or would you say no, Abiraterone and Enzalutamide, like we heard from Silke, is a good treatment for that patient? Who is for one? Who is for the option 2, radiation? Okay. Who is for the option with Cabazitaxel, a second line? Who is for Abiraterone? And who is for Enzalutamide? Okay, I see Harald will do everything. Why not go for Docetaxel again? We have some data, and of course you can go for Cabazitaxel because it's a second-line therapy, and Abiraterone and Enzalutamide. But the answer, the first therapy was very good to Docetaxel, and we see there are some studies, Lorenzo presented in 2010. When you go in a retreatment with Docetaxel and you have a good response to the first treatment of the first therapy, chemotherapy, 50% of the patient will have a good response, and you will have a benefit in overall survival of 3 months. So this option is not so bad. We start with this re-challenge, and you see the patient didn't tolerate it very well. Just 4 cycles, the patient had high neutropenia, and the PSA was unchanged. This is the MRI, horrible. And now the question is, the patient was progressive in August 2012, and we talked to the patient to start with a chemotherapy, but the patient wanted to have the new agent, the new drug, Abiraterone. We start with Abiraterone and with a pain management. And what happens? Just 4 months later, we see a progression under Abiraterone, just 4 months later. Radiological and clinical progression, PSA 320. So I think this option is not so good. We know we have a good answer to the chemotherapy, and now the question again, would you say a re-challenge? Would you say a chemotherapy with Cabazitaxel will be the right, or would you go for Enzalutamide? Who is for 1? Who is for 2? We can't do a radiation because everything was already radiated. The chemotherapy here is the right option. You know the TROPIC trial, we saw this, Silke presented us this data. But have Cabazitaxel efficacy after Abiraterone and Enzalutamide? Yes, it have. We have small data of that. 50% of the patients have a good response. And the question is, what is better, to start with Cabazitaxel before or after the new agents? You see, you can double the time. Median overall survival and median radiological progression-free survival. But you have to remember, these are retrospective studies and small studies. We need more good data for that. What happens here? 6 cycles of Cabazitaxel plus GCSF because of the neutropenia, and the PSA dropped down to 29. The imaging was unchanged. We were very happy about this result, but just 2 months later, again a progression. What are the options? Palliation, re-challenge, Xtanti, Enzalutamide, Xofigo. We talked to the patient to go for Cabazitaxel for the next 4 cycles, but the patient didn't want that. He decided to go for Enzalutamide. And the question is, Xofigo is introduced in November 2013, and we can start with that. And what happens? When we start with enzalutamide, the PSA in the first month go up. This is a normal thing. In the first months, it is allowed that the PSA grow up. The ECOG performance status was unchanged, and the patient didn't need any opiates. And 1 month later, PSA go down to 100. The question is to you, would you start now with alpharadine? I think this is a very, very interesting question. What is the best time to start with its new agent? Every time in our hospital we are talking about that. But the solution is not clear for us. What are the options? You see, 2011, we have Abiraterone and Cabazitaxel. 2013, Abiraterone before Docetaxel, after it, and you can combine, and after that you can go for the third-line therapy with Cabazitaxel, and of course, you have to change it. Alpharadine, you can start every time with alpharadine. But what is the perfect time for that? And what is the future? I think in our daily practice, we have to look to the history of the patient and look how was the result of the hormone treatment, how was the result of the chemotherapy, and we have to decide and for the patient what is the best treatment. Thank you very much for paying attention.
Okay, I think we will continue, Howard, and then we discuss everything together. Would this be okay for you? Is it on?
Now it works. Okay. So I'll start over. I have no slides, you'll be happy to know. And the 2 presentations we heard, I think, beautifully... have no slides. No slides for today. No. Beautifully illustrate the issues with the new ways we're thinking about metastatic castrate-resistant prostate cancer. And the cases, I have to say, the management, I have nothing to add. I think your management was perfect. I think everybody should refer their medical oncology questions in prostate cancer to Lukas. And it's very impressive as a surgeon that you have such a sophisticated appreciation of the use of all these new medicines. 6 drugs approved in the last 3 years, and 2 of the drugs can be used pre and post enzalutamide, not yet approved pre-chemo, but it's probably coming. And so there are so many options. We don't know what the best sequence is. There are some excellent references. I can give you, if you'd like to read a little bit about this, but you mentioned all the things that we struggle with, and the solutions you proposed, I would agree with. The radium-223 can be used at any point. We don't use a lot at NCI. We're very much driven by the studies that we're doing, so we're not maybe the best to say what the real world answer should be. But I think our bias would be to use it relatively early, the alpharadine, because there's so little myelosuppression. There is a survival advantage. In the subgroup analysis of the Alsimca trial, every subgroup benefited, but the only group that didn't really benefit was the less than 6 bone mets. There you have a very wide confidence interval with the point pretty much right on the 1.0. So with more bone metastasis, clearly that would be the place where I would go to the alpharadine early. But again, there is a survival advantage, and you don't want to overinterpret subgroup, post-hoc subgroup analyses. So I think you have an option, and you should be thinking about the alpha rating early. You're not burning any bridges as you would in the old days with these radiopharmaceuticals because there's so little myelosuppression. The one thing that maybe we think of a little differently is the immunotherapy. This has not been approved, or I think only recently approved in Europe, but maybe not available even though approved, and it depends on which country. And I'm referring to the Provenge or Sipuleucel T from Dendreon. And this is a problematic area. There are definitely some concerns about the phase 3 trial. I have to say I'm a little more skeptical than my colleagues at NIH who are much more knowledgeable about immunotherapy. I'm not an immunotherapist. The immunology branch at NCI seems to have more confidence in the Sipuleucel T data than I do. And I was talking yesterday with Lukas, and we agreed that there was not really a true placebo group in the Sipuleucel T randomized trial. And there is a theoretical concern that not getting back the leukapheresis cells may have caused a detriment. I think it's curious that the benefit was all in the older age group, which is the opposite of what you would expect for immunotherapy. But if you want the NIH perspective, I think maybe because they are maybe more inclined to accept the benefits of immunotherapy because that's maybe what they do. They're more enthusiastic and less critical, and they have immunological answers to all of my criticisms. So they would be more believing that there is a true benefit. And I must say that some recent data that I saw makes me more a believer in the Sipuleucel T, which is that post-enzalutamide, they're seeing remarkable PSA responses. Because as I should mention, we don't see responses in tumor size or in PSA with the Sipuleucel T. But post-enzalutamide, they are seeing PSA responses. And that makes some sense because enzalutamide increases the thymic weight in mice, it increases T cells in the thymus, and it may be sort of an immune system priming agent. And this is why everything is getting much more complicated as we bring immunotherapy into the mix. At NIH, the immunology group has developed the Prostate or PSA Tricom vaccine that you will be hearing more about in the near future. A worldwide phase 3 trial is near completion with a sample size of about 500. And this is in follow-up to our randomized placebo-controlled phase 2 trial of this pox viral vector vaccine, the NIH vaccine, Prostvac, which shows exactly the same curves as you'll see for the Sipuleucel T. It is a remarkable thing. No change in progression-free survival, no effect on PSA, but an improvement in overall survival. The Sipuleucel T was a 4.5-month improvement, the NIH vaccine an 8.5-month improvement. That's not to say it's better, but the curves look identical. And when you look in the subgroup with a good expected survival based on the Halabi nomogram, it's a remarkable increase in survival, 30 months or so. And so we're very excited about this. Of course, we'll need the phase 3 trial to confirm what we saw in phase 2. Again, overall survival without progression-free survival. Now you might ask yourself, how is this possible? This goes against everything we have been taught in oncology, where we expect to see responses and we expect to see improvement in progression-free survival before we see an increase in overall survival. But with some very interesting modeling work, and just thinking, if you do the thought experiment, it's not difficult to understand how you could have an overall survival advantage without progression-free survival, because it's really an artifact of how we measure progression-free survival. We do scans at intervals, and so if you have a drug which is just slowing the growth rate but not causing a response, you can see easily that it's possible to have a prolongation of survival because you slow the growth rate. Instead of a more rapid growth rate where you get to death, you have a slower, so you're always progressing. So progression-free survival is the same. If you measure progression every week, then you would see a slowdown in the progression. But because of the way we measure progression, you don't see progression-free survival improvement. But by the thought is that by reducing the growth rate, the speed at which the disease is progressing, you then can come to an overall survival advantage. And so we've seen exactly the same thing with the Prostvac vaccine. I'm actually going to show those curves tomorrow because our next step, and we're just starting a study to look at this Prostate vaccine in the active surveillance population, because we want to move these immunotherapies earlier and earlier. So that gets back to the point of where would you, the only thing we might do differently is think about immunotherapy very early on. And the beauty of this is that you give the immunotherapy, the vaccine, and then you go right to the next step. You don't wait for a PSA response, you don't wait for a clinical response, because you're not going to see it. But it may be that over the long term, that there's at least a subgroup of patients that will have benefited by having gotten the immunotherapy early. I'll just say maybe one or two more words. We have Abiraterone and enzalutamide. We don't know how best to sequence these two drugs. We do, I think, have some data now that enzalutamide after abiraterone has about a 50% response rate, but a relatively short duration of response, only about 4 months, which is about half the duration that you have when abiraterone is given up front. But you have definitely responses not very long-lived. The other way around, abiraterone after enzalutamide is a very low response rate. So if your idea is to maximize the response of both, then maybe abiraterone would be better first. Even though I think those numbers are good to know, our bias is now to give enzalutamide first in order to avoid the steroids that you have to give with abiraterone. And so in terms of sequencing abiraterone and enzalutamide, we're tending to give enzalutamide first. You should know that they've never been compared, but there is retrospective data to suggest that enzalutamide after abiraterone produces better response rates than abiraterone after enzalutamide. So maybe I'll stop there, and thanks for letting me comment. And these are a very, very good session. Really appreciate the insights that you had. Thank you.
Thank you. Maybe Silke and Lukas, you come up and then we can discuss this topic, because I think there are